So by this we reach to the end of the first part, and I'll see you again in the second part. Assalamu alaikum wa rahmatullah. Welcome back to the last part in this lecture, talking about the possible periapical diagnoses. So what are the possibilities? So it's either you'll have a normal tooth, normal periapical area, you'll have acute apical periodontitis, acute apical abscess, chronic apical periodontitis, or chronic apical abscess, or condensing osteitis. So these are the conditions where you, or the possible periapical diagnoses. Let's see how they are presented. So let's talk about the periapical pain. Periapical pain is completely different than pulpal pain. Pulpal pain is transmitted or is felt, the nociceptive feeling is transmitted via the free nerve endings through the C nerve fibers that reaches to the brain. And you will feel that it is sharp, lacerating pain. So it's a sort of a superficial pain when it is in the reversible form. And in periapical pain, the problem is different. Now the proprioceptors are stimulated, which are located in the periodontal ligaments, and this would give you a different feeling, different type of pain. Usually the pain is sort of a deep, we call it deep musculoskeletal pain. So it's deep, affecting the bone, affecting the proprioceptors. And because the periapical area is affected, the tooth is sensitive to percussion, and the patient cannot chew on that tooth. So the patient would come tell you that, he would not complain from sensitivity, but he would tell you that I can't chew, I can't eat on that side. So this indicates periapical problem or periapical lesion. And the pain could be, mild, moderate, severe. It depends on how acute is the condition. So this is what's specific regarding periapical pain. What's the difference between periapical pain and pulpal pain? So let's see the possible clinical scenarios. The first one is having acute apical periodontitis. In acute apical periodontitis, the problem is not restricted to the pulp anymore. There's necrotic substances that manage to get out of the pulp through the apical foramen, reaching to the periapical area here. The periodontal ligaments here that you see would get inflamed because of the presence of the necrotic material, and will create an inflammatory response. So white blood cells, neutrophils, lymphocytes would come and accumulate in this area. So there is an inflammation, there's collection of fluid here in the periapical area. And again, this area is restricted. It is just between the root and the socket, the dental socket. So again, there is restriction in space, and this is why it is associated with severe pain in case of acute apical periodontitis. Now, you might have the two conditions occurring at the same time. You might have acute irreversible pulpitis and acute apical periodontitis, and this happens when the pulp is still vital, but it is irreversibly inflamed, and necrotic material at the end here at the periapical area, necrotic material managed to get out of the apical foramen and initiate the periapical inflammation. So the patient would feel both types of pain, would feel the intense, severe throbbing pain from that tooth. At the same time, he would feel the sensitivity to touch, or he cannot touch that tooth. The tooth feels higher than normal, and this is a usual complaint of the patient, that he would tell you that this tooth is out of its place. It is higher because, of course, related to the collection of fluid at the periapical area. So these two conditions might occur or commonly occur at the same time, both irreversible pulpitis and acute apical periodontitis. And what you need to do? Well, usually you need to confirm this by tenderness to percussion. So the tooth would be tender to percussion when you do a periapical percussion on the tooth. Some patients would think that the problem is related to the gingiva, because he would notice excessive redness and swelling in the gingiva at the site of involvement. So this is one of the presentation of acute apical periodontitis. Sometimes when the bacteria is so virulent, so aggressive type of bacteria, it would induce a massive inflammatory reaction, and the inflammation would reach to the gingiva and would be presented with swelling and redness. So this is how clinically it can be presented. When you take a radiograph, I think we have a radiograph here, yes. So when you take a radiograph, you will see, I'm not sure if it appears, if it is clear to you, but normally we have this lamina dura here, and which is a radio-opaque line that surround the tooth, and this is in the real anatomy, it is the compacted bone at the tooth socket. So because of the inflammation in the periapical area, this lamina dura, or this compacted bone, would be, affected. There would be an initial loss of the compacted bone, and this would appear radiographically as loss of the lamina dura. So you can follow the lamina dura here, and then it is lost because now there is an inflammation in the area, there is collection of a fluid, and the same applies here. You might see a hazy lamina dura, so it will start as a sharp line here, and when you get to the periapical area, it will start to be hazy. At the very initial stages of acute apical periodontitis, if the patient came to you immediately next day, you might not see anything in the radiograph. There hasn't been enough time to make changes that can be detected radiographically. However, after a few days, you might start seeing changes in the periapical radiograph. It started with the haziness of the lamina dura, then complete loss of the lamina dura, and then when you wait longer, more changes can be seen. And the treatment of choice, so if the tooth is restorable, RCT, if not, do extraction. When we can say the diagnosis is acute apical abscess, when there is an evidence of abscess presence, then you can say your diagnosis is acute apical abscess. Otherwise, just stay, general, stay safe, and say acute apical periodontitis. So abscess, if you can see fluctuation, for example, if the tooth if the gingiva is red and swollen, and then if you can see a fluctuation, that indicates the collection of pus, and when you do the incision, a pus come out. Now this is an evidence of pus, and now you can make a diagnosis of acute apical abscess. Or if, for example, the tooth is badly broken and you can see the pus is coming out, is oozing out here from the tooth, from the cavity, then you can say acute apical abscess. Otherwise, you cannot tell. With the changes, you cannot tell. With the radiographic changes, the only way to confirm that it is acute apical abscess is seeing an evidence of the presence of abscess. The treatment is exactly the same, but we add here incision, because no treatment is complete without getting rid of the pus. If there is pus, you need to make, and if you can feel it in the gingiva, you need to make an incision, drain that abscess, and you need to open the chamber here and drain the pus out. While this is not necessary, when there is just inflammation, you don't need to do any incision, and if you did, only blood would come out. So we do incision only when there is evidence of pus collection. And what type of treatment when there is an acute apical abscess? This is a case of emergency that you need to treat, not just to prevent or to stop pain, but also to prevent complications. So Drainage should be established either by opening the pulp chamber or by doing an intraoral excision. If there is accumulation of pus extraorally, and I mean here pus, not cellulitis, because cellulitis might be, accompanied with the periapical abscess. So the patient would have, swelling of his face, and this swelling is related to cellulitis, not to the abscess. The abscess would be just at the site of the tooth. So you need to establish the drainage, as I said. If there is a fluctuation that you can see extraorally, this is definitely need to be referred to the oral surgeon to do extraoral incision. For intraoral incision, you as a general dental practitioner, you can do intraoral incision to drain the abscess. Rinses with a normal saline is very helpful. It reduces the inflammation, it improves the drainage. Analgesics, of course. When to prescribe antibiotics? Well, if there is a cellulitis, you must prescribe antibiotics. If there is no cellulitis, it depends on the general status of the patient. So if the patient is young, in a good health, you manage to do good drainage, then antibiotics are not needed. Analgesics, I would go for non-steroidal anti-inflammatory drugs, because here the problem and the condition is inflammatory in nature. So prescribing anti-inflammatory would reduce the inflammation and relieves the pain in a better way than paracetamol, for example, that does not affect the inflammation. So I would go for NSAIDs for analgesia, and I would prescribe antibiotics if there is a cellulitis, there is extraoral swelling, or if the patient's general health is not that good, prescribing antibiotics would help, because antibiotics has been shown to not just reduce the infection, but also they have analgesic effect and they have anti-inflammatory effect. So it depends on the patient's general health. Good, let's say young, healthy patient, no need for antibiotics if you give him good analgesia and good drainage of the pus. Right. So this was regarding acute apical periodontitis. Talking about chronic apical periodontitis. So chronic means it has been there for a while. And because it has been there for a long time, it managed to do certain changes within the periapical area. A thing that I want to reinforce here when you get to the clinics, hopefully next year, is when we do radiograph, and we will do lots of radiographs for our patients, and I'll ask you, or any of the faculty would ask you about what you see in this radiograph, and you will hopefully manage to find the answer and describe this as a rarefying osteitis, which is correct. When you want to do the diagnosis, when I ask you for the clinical diagnosis, rarefying osteitis is the radiographic findings. So you are telling me that there is a bone loss in the area. So you describe it as a rarefying osteitis. But when I ask for a clinical diagnosis, it needs to be chronic apical periodontitis. If there is no symptoms in the area, in the tooth. So this tooth, presumably, or there is no symptoms, the patient is not complaining of anything, you just did a checkup because of the caries here. There is caries here in the distal side of the tooth, and when you took a radiograph, you found that there are changes here in the periapical area. There is rarefying osteitis, a little bit of condensing osteitis here and there surrounding this tooth. So your clinical diagnosis would be chronic apical periodontitis. Now, what is in here? Well, if we, for example, took a section, and if we took the tooth out and took this here, this area, and we examined it histopathologically, we most likely we would see granulation tissue. We call it granuloma. It could be just traces of chronic pus there, and it could be a cyst, not for this one, but when it is big in size, it's more likely to be a cyst. Now, these changes we cannot, confirm it. Unless we took a biopsy and we took it out and examined it under the microscope. Otherwise, we cannot confirm whether it is a granuloma, there is abscess there, or there's a cystic changes. We cannot confirm it. However, when it is big in size, when it is localized and corticated, so these, having a localized corticated round structure, this is more indicative of a cystic lesion. But when it is small in size, you definitely, you are just guessing, and you are going with the best guess. And from the clinical point of view, it doesn't make a difference. It will make a difference if it is cystic, and if it is small in size, no problem. But if it is, there's evidence of being a cystic lesion, it's better to be managed and followed up. The chronic apical periodontitis can also be presented as a condensing or sclerosing osteitis. I think we have, here. So this is an example of a caries tooth. There is recurrent caries under the filling. And I can see here some sort of rarefying osteitis, but there is a sclerosing osteitis as well. So this is one of the presentation of chronic apical periodontitis. You might see a root resorption. I believe this root is resorbed in this area. So when you see a blunt, end of the root, this is suggesting a root resorption. Again, the treatment based on the tooth condition. If it is restorable, we'll do root canal treatment. If not, extraction is the treatment of choice. And here is an example of rarefying osteitis. You can see the rarefying osteitis. Now, this might be cystic. It is more of a localized. It might not. It might be just a granuloma. You never know. And in addition to these, we can see here the furcation involvement. So all of these are different radiographic presentation of chronic apical periodontitis. This is another one with a diffused rarefying osteitis. Now this is a big one. This could be a cystic lesion, and it's not necessarily to be corticated. It is corticated when it established its size, but if it is still expanding, it will not be corticated. So this could be a big granuloma, could be a cyst. There's no way to confirm it except with a microscope, or when we see an evidence of a cystic changes being corticated or well localized, like this one, for example. This is more of corticated, well localized, so this indicates most likely to be a cystic lesion. And I would write this down for the surgeon who's going to do the extraction. If I am going to do the extraction, I would extract this tooth, take this remaining root out, and you need to curate this area to make sure that you removed any epithelial tissues, any cystic areas, any cystic lesions in the area. So you can see how corticated it is here, how it is localized. So this, you'll go with a better guess of having a cystic lesion in such conditions. Okay. Chronic apical abscess, and again, I would say abscess only if I can see the evidence of abscess. In acute apical abscess, we could see the fluctuation of pus under the gingiva, or you could see the pus coming out of the badly broken tooth. And in chronic apical abscess, again, you would see the pus, and it is, the pus would keep accumulating and will find the weakest way or the weakest part of the bone to make a track to it, and then perforate within the cortical bone and start accumulating under the gingiva, forming this pus, this abscess here. And eventually this would perforate and the pus will come out. So the patient would tell you that Every now and then I would have like a boil here, like a gum boil coming out from the gums, and then it will burst with thick material is coming out, and then it will heal for a couple of months until it will swell again, and then a pus would come out, or the patient had to squeeze it himself. So you will see the evidence of abscess here. This is a sinus tract here. This is a pariemus, and you can see the evidence of pus or the site where the pus is coming out. So in this case, we call it a chronic apical abscess. Radiographically, it will appear, exactly the same as chronic apical periodontitis, and the treatment options is still the same. The complications of periapical periodontitis is the spread of infection. So for many patients, the chronic periapical lesion would remain as is forever. So the body managed to localize this infection. The radiolucency is surrounded with condensed bone, trying to localize the lesion. However, in other conditions, particularly when the patient's immunity is suppressed and goes down, this might induce a flare-up in the chronic periapical lesion and spread of the bacteria into the bone. And usually the patient would come complaining of a bone pain, diffused pain in the area, deep aching pain in the area, and when you take a radiograph, you will see changes of mixed radiolucent and radio-opaque areas, or we call it mottled appearance. And sometimes it is just purely sclerotic changes related to chronic type of osteomyelitis. In acute osteomyelitis, there might be an infection. There might be sinus tracts coming out. Of course, the patient would not be feeling well, and they will complain of fever and severe pain. So by this, we'll reach to the end of this lecture. See you next time with a non-dental pain lecture. See you. Bye-bye.